pinpoint. It's pushing.
Who's from Stanford, amazing career she's had, and now one of the budding female stars from US. Off you go, Corinna, all yours.
Thank you very much, Salman. And for some reason, it says host disabled participant screen sharing. Are you able to fix that?
I stopped share. Maybe that's.
Oh, maybe that.
Yeah.
I'm still getting that message. I don't know why, because
now I made you co-host.
Wonderful. Thank you. Well, thank you, Salman, very much for the invitation to speak here, and some really interesting cases from Dr. Hartle and Dr. Chan. I have been asked to talk about thoracic fusion techniques. I will try to go quickly. Here are some relevant disclosures for today's talks. So my understanding is that we have a mixed audience today that includes some trainees and obviously some very senior surgeons. So when we're talking about thoracic fusion techniques, it's important obviously for us not to forget our basics and our anatomy. Quick question, can you all see my moving arrow?
Yes.
Okay, perfect, wonderful. So just as a reminder to everyone and to all the trainees who are here, and this is something that I keep in mind every time I do a thoracic case and a thoracic fusion in particular. You want to identify the transverse process, you want to identify the pars, and you want to identify the facet joint. And it's very important that you see that anatomy so that you know anatomically where your screw entry points are going to be. So for some tricks that I've learned from various folks along the way, this one actually comes from Dean Chow. Roger, I think he's one of your colleagues now, but he always used to teach me that this is like learning where the skier is falling off the cliff, this point right here. Another technique is looking for your cortical blush. So you can start and you can actually use your drill and you can kind of continue to drill until you see that cortical bone that's really bleeding, and that can lead you to the thoracic pedicle. And a lot of times in various patients, the transverse process can be more vertical. So I will use a Lexel and take that off in order to help me identify this point. And I do a pretty meticulous bony exposure, I think probably a little bit more orthopedic than neurosurgical for some of those folks on this call. And I find that when you do identify your anatomy, your entry point for the thoracic screw becomes much more clear. And finally, the other option, and so one of the places where I trained at Hopkins, actually, I felt that they were very old school. And so some of the surgeons there would actually do type 1 osteotomies and remove the inferior facet for every single case where they were doing a thoracic fusion in order to facilitate the bony fusion. And so for doing this, I'll actually use a straight osteotome and take off that aspect of the inferior facet. And I found that that really shows you where your entry point is going to be. So these are some of the tricks for the trainees that I've learned personally when doing freehand thoracic screws that help me out. Obviously many folks have seen this diagram from one of Lenke's famous papers, and you can, learn that some of the differences between the entry points for the thoracic pedicle screws at different parts of the thoracic spine. But especially if you're dealing with a revision case, if you're dealing with a patient with scoliosis, you'll find that you can't always, things don't always look like this diagram. And so that's why some of those tricks are particularly useful in the operating room. Obviously, we all know in terms of placing our pedicle screws. So I used to use the Lenke probe, and the first 10 to 15 millimeters for trainees are the most important. That's where you can get your medial breach. And now I actually do my screws using the power drill. And I found that you're able to get a pretty good tactile feel once you get used to using the power drill. I do also tap, and I routinely under tap by 1 millimeter in terms of increasing insertional torque. And for the most part, most of us are using polyaxial screws these days, especially in the thoracic spine. But there may be certain cases when you want to consider using revision screws. And I will be talking about some MIS thoracic fusion approaches as well. So now getting into some of the more interesting things, I think it's important for all trainees really to understand the basic anatomic landmarks, because even though we're using navigation and all these fun technologies, we still have to remember the basics. So the reason for using navigation is because we want the highest accuracy and the highest precision for every case that we do. And the reason is that bad things can happen. So this is obviously a tragic case, but even in the hands of some of the most skilled surgeons who've been putting in screws for decades and decades, the accuracy of freehand thoracic pedicle screw placement is actually not that great. This comes from a meta-analysis that we performed. And you can see here as we are going from conventional, so freehand thoracic screw placement accuracy is about 50%, to fluoroscopic assisted 78%, and then using 3D navigation over 90%. So we kind of liken this, conventional freehand approach to using a compass when we all have GPS on our smartphones nowadays. And when we did a meta-analysis of over 50,000 screws that were placed, CT navigation had the highest accuracy across all different types of screws. Today, obviously, we're focusing on thoracic screw placement. And in particular, robotic assistance actually had the highest accuracy in thoracic spine in this meta-analysis. So I'll take you through a few cases using two different kinds of navigation. The first is using stealth navigation, which is one of the most well-known systems with Medtronic. And so this is a case of a navigated hybrid MIS fusion approach for a tumor. This was a 77-year-old man who presented. He had a history of prostate cancer and a status post-prostatectomy with a rising PSA. He came into an outside hospital emergency department with 5 days of lower back pain, progressive lower extremity weakness, and had been unable to walk for the last 36 hours. You can see his strength exam below, 3 in his IPs on the right, 4 quad ham and plantar flexion, 2 dorsiflexion EHL, 2 in his left IP, and 4 minus distally in the left lower extremity. So you can see his imaging here showed multi-level disease, and he did have both bony metastases as well as epidural disease with severe spinal cord compression, fortunately coming dorsally here. And we've seen some beautiful cases from Dr. Chan and Dr. Hartle showing some anterior decompressions. Given that this was metastatic disease with a known primary and we had severe spinal cord compression at this level, this is one that I thought was a very good case for a fusion approach. So MIS fusion, 3 levels above and 3 levels below for the screws, and then a mini open laminectomy with epidural tumor resection for T8 to T10. And you can see is the postoperative construct here. So in terms of steps for using stealth navigation, I'll just take you through it really quickly. We obviously position our patient on a radiolucent Jackson table as we normally would. I actually open the skin with the midline incision, especially when I'm doing a really large construct like this. I find doing the train track skin incisions are not particularly cosmetically appealing. We use a C-arm to approximate the level before skin incision, and then open the midline to expose the spinous process superior or inferior to the levels of interest. This is really important. At this point, we'll place our spinous process clamp. We've got both the single and the double clamps that I tend to prefer using this navigation system. And importantly, you need to make sure that your spinous process clamp is out of the way of the areas that you are going to be instrumenting, and that you are also considering the thoracic kyphosis with regards to where you're positioning your clamps and where you are positioning the stealth camera, because you want to have a line of sight that goes from stealth camera to your spinous process clamp and then is seeing the instrument that you're using, whether it's the tracker or the drill, etc. And so sometimes, especially if you have a very long construct like this one that I'm showing in this particular example, you can actually put a spinous process clamp at the top and the bottom and have cameras at the top at the patient's head and the feet, and that will help you to be as efficient as possible with the navigation. So you bring in your O-arm and you perform an O-arm spin, and then you transfer the images over to the stealth navigation system, at which case you can then use your navigated probe to plan your stab fascial incisions. So even though I do a midline incision through the skin, I will then do stab fascial incisions on the side. So you can see this particular diagram, what I'm talking about with the line of sight. You want to make sure that you're keeping in mind where your camera is, where your spinous process clamp attachment is and where your instruments are. And for patients who have a very severe thoracic kyphosis, you have to be smart about where you place your clamp and your camera. Use your bovie to go down to bone. As I mentioned before, I have switched over to using navigated drill system. So I use a navigated power drill for the screw trajectory. And then on the stealth screen, you can see the different views that usually will have I will usually have two views shown up on my screen. I do use K-wires. The reason why I like using K-wires is because they allow me to have some sense of feel. So I'll essentially use a K-wire like a ball tip feeler probe, and I know that I always have a depth. And so this, I think, allows a nice blend, because if, for example, something feels soft with my K-wire, I have a way of knowing that my navigation is off, which you wouldn't otherwise necessarily know. So after I use the power drill, I'll place a K-wire. I use a navigated cannulated tap over the K-wire. And this is an example. And then finally place a navigated cannulated screw over the K-wire. And this is an example of one of the ones that I use. So I find this to be a very nice way of doing these MIS fusions. I do personally obtain an intraoperative O-arm spin to confirm screw placement, but that's obviously up to your own preference. And then here's an example showing then afterwards, since we have a nice midline incision, I can then do a standard laminectomy over the area. In this particular case, the 3 levels that had the epidural disease. Place rods with MIS rod inserters, which are pretty standard. And really importantly, especially for the trainees, is especially when you're doing long MIS constructs, check your rod length. Sometimes you can't see it very well on the lateral C-arm, but if you look at an AP, you should always be able to see rod above and below your top and bottom screws. And then finally, I'll use the navigated Midas burr, and I'll use that to decorticate and get into the facet joints and inject TBX there, because I think we oftentimes forget when we're doing these thoracic MIS fusions that putting in the screws is part of the case. And we also need to try to facilitate a fusion as well, especially in some of these cancer patients. I find that the stealth MIS fusion approach in the thoracic spine is also great for fractures. So these are some examples of a 3-column fracture on the left and on the right, where I use the MIS approach. And you can do this. It's especially nice if you don't have to do a decompression, but then you can also do sort of this mini open approach and do a decompression open laminectomy as well if needed with the MIS screw fusion approach. So as I mentioned, I think that the stealth navigation MIS thoracic fusion is ideal for trauma without significant compression. I think it's great for these hybrid mini open separation tumor surgeries. And some of the, pearls I talked about was mentioning using 2 clamps or stealth stations for longer constructs, optimizing clamp placement, always being aware of where the clamp is and not moving it, and making sure your residents and fellows are doing the same. And keeping in mind that navigation can be off if you manipulate and retract soft tissue too much. And this happens with some of our patients, and there's definitely a limit to the size of patients, even with MIS. I know this one is a problem more in the lumbar spine. We don't usually see it quite as much in the thoracic spine. Secondly, I wanted to talk about another navigation platform that I use routinely, which is 7D. So this is an example of a 7D navigated open fusion for a thoracic trauma case. And you can see that this was a 52-year-old female pedestrian versus auto with multiple traumas who had this T10 unstable fracture. So with regards to 7D, so this is machine vision navigation. So this uses similar technologies as what you have in the self-driving Tesla cars. So in this picture in the middle here, you can see this, the surgical light provided by 7D, which actually has a bunch of machine vision cameras. So it is taking a picture of your open, it's taking a picture of the field, and then it is registering that with your preoperative CT scan that you've obtained. So in contrast to the stealth navigation, you do not need to get an or many of the other platforms that are out there, you do not need to get an intraoperative CT scan. So it saves that time. So disadvantages are that, even though they do have an MIS option, option. This is based off of machine vision technology. So it needs to see the anatomy, it needs to see the spine. And so that's why this is a case of doing it in open situation. I thought that it was a particularly nice use of 7D for this very unstable fracture, which you saw in this particular case for this trauma patient, because one of the issues you can have with your navigation platforms, any navigation platform that requires an intraoperative CT scan, if your spine is very, very unstable, even if you put 2 spinous process clamps on, if you have any movement of your spine relative to the clamp, then your navigation is off and you would need to do another intraoperative CT scan, which takes time. So I think that 7D can be used fairly nicely in this type of case. So just to take you through what the workflow looks like very quickly, we position our patient in a standard fashion. Once again, this is to do a thoracic open fusion using 7D. We will use the C-arm to approximate our level, perform an open exposure down to the lamina and the TPs. And really importantly for 7D navigation technology is meticulous soft tissue removal. So you need to have your bone very, very nicely exposed. And that is important in order to get a good registration. You place a spinous process clamp near your region of interest. Then you bring the 7D machine over the field, remove other lights, and you take a flash registration, which takes a few seconds, which is actually taking a picture of your open operative field. You then need to select points on the patient anatomy that align with your plan. So here's an example of a case point selection for a thoracic case. And very important, you have to know exactly what level you are at. So for the trainees on this seminar, there obviously are a lot of different ways that you can localize in the thoracic spine, but it is extremely important that you are accurate with your thoracic spine localization. So for me personally, I do AP shots. And I count the number of ribs on the preoperative imaging, and I put a small instrument into a pedicle, and that's what I use. I don't place things on, I don't place things underneath lamina in the thoracic spine, just given the given issues of stenosis, and I don't place instruments on spinous processes because they can really shingle over and you can be misled. And you have to be accurate in terms of your level with 7D. Then you confirm your accuracy of your registration. So the more number of green points here, these are points that are co-localizing from your current, the current flash registration to your preoperative CT scan. So this is an example of a lot of green on these levels. So that's a promising registration. And then you have a very similar workflow as you would with other intraoperative CT navigation platforms. So you use a navigated probe, you determine your screw entry point, you see all the usual views that you would have on your stealth navigation platform as well. Use a navigated power drill to drill the screw trajectory. You could also use a Lenke probe if you prefer. You can use a navigated tap to tap your trajectory. In this particular case, since we are doing this, this was an open approach, but so this is a concept called the virtual K-wire. Okay, so the screen on 7D, and this was probably one of the things that took the most getting used to when I started using this technology a few years ago. You are not able to navigate as many instruments as you are with the stealth navigation platform, and the 7D platform is also agnostic, so you can use any screw system. They show you something called a virtual K-wire, which is this blue line on the screen. And so you can use that with any instrument that you put into the field. You can hold up your hand, the camera is looking at you, and that virtual K-wire will tell you the trajectory. So I will tell you that it does take a few cases of getting used to. It's not as intuitive as the other screen, but now I use it routinely and it's very effective. We've seen quite a few of these, but this is just to show you that you can use the 7D navigation for revision fusions as well. So here's an example of a revision fusion not done by myself, someone else, unilateral screws placed here, and you can see this calcified disc. So you are actually able to register off of the prior screw and rod that were placed by the prior surgeon, and then get good accuracy in order to both place the screws as well as to see exactly where I was in terms of doing I did this posteriorly through a transpedicular approach, and I could see how much of this calcified disc I had removed. And here's the postoperative imaging. So 7D is great for open cases where large open decompression is needed. I think it can work really well for these unstable spine fractures, as opposed to stealth navigation or other intraoperative, CT navigation-based systems. If you move the clamp, all you need to do is just take a very rapid flash registration, which takes a few seconds, as opposed to getting another intraoperative spin with your CT scanner. So it's very efficient in that way. But it does require very meticulous bony exposure with soft tissue removal and suctioning of any blood in the field. You have to really pay attention to lighting and shadows during your flash. You have to be very smart about point picking in order to get optimal registration, especially at the levels at the superior and inferior aspects. And then you have to keep in mind, this is really important, especially because I'm working with trainees in each case, there's a different line of sight than stealth. So in stealth navigation, you get used to the camera being at the foot or the head of the bed, and then it sees your spinous process clamp, and then it sees your instruments. With 7D, the camera is above your head. So a lot of times, especially if you're working with an assistant, their head can go in the way and it can interfere with the line of sight. So you have to get used to a different line of sight for this system. And then today's conversation is not really about lumbar fusions, but some of the most challenging cases for 7D I've found to be, like, for example, one level, L4-5T lifts, because there's a lot of tissue and shadowing in there that makes the machine vision technology not great with regards to all of the shadowing that you see in your flash registration and difficulties with good registrations with your preoperative CT scan. So in conclusion, it's critical to know the anatomic landmarks for thoracic pedicle screws. I do think that navigation is becoming the gold standard, at least in the United States, and there's different navigation platforms have specific advantages and disadvantages. And there's some great MIS techniques that are really helpful in trauma with or without significant compression, and can also be great for hybrid mini open and separation tumor surgeries. So thank you very much to our team at Stanford. Here's my contact information for anyone who would like it. And then a quick pitch that we're going to be doing a WFNS spine section symposium at our upcoming spine section meeting in 2024, talking about global neurosurgery and global spine surgery in particular. So I hope you'll all be able to make it.
Do you mean we have to use routinely the navigation? Do you mean this?
Yeah, I do think so. I realize that practice is different in different parts of the world. I think at least in the United States, to be honest, partially our legal climate contributes a little bit to that as well. But I think that when you have the resources and you're at an institution where you have navigation, I think that there really isn't an excuse for a misplaced screw. And when you look at the numbers from our meta-analysis, I know a lot of the older people on this call will say that all their screws are perfect, but it's about 50% of thoracic freehand screws are placed well. So I do think that if you're in a facility that has access to navigation technology, you don't really have an excuse for a misplaced screw. I think the hardest thing really is the most challenging thing, I think, is training our new residents now, because, when I trained, I actually did mostly freehand screws with a tiny bit of navigation. But now, and when I started at Stanford 4.5 years ago, there are 5 spine surgeons, and I and the other youngest spine surgeon were using navigation, and the other 3 were not. And now over the last 4.5 years, all of the spine surgeons use navigation, fairly routinely for cervical pedicle, always for cervical pedicle screws, for thoracic instrumentation, plus or minus on lumbar screws. So it's really been, a recent change. And so our residents don't necessarily always get the opportunity to do as many freehand screws now, which I think is a problem, because it's important to have, to understand that anatomy as well. But that is definitely the shift that we're experiencing, at least in the US.
I think another shift is going to be robots are going to take over, and then in 4.5 years' time, you will be out of business, unfortunately, or at least you'll be doing much less work and just watching it majority of the time. The problem with, again, with MIS is whatever you feed in and how accurate you have gone in, how meticulous you have done with your preparation, it's going to be fine. But if you didn't and you were not careful enough, then you'd cause problems, obviously. The other same thing with a robot, this robot switching off in the middle of surgery, all those stories and, doing the wrong thing for you. So I think we need to be careful where we're going. But yeah, I agree that technology will take over, but we have to be careful that we all learn the technology and make sure it's helpful for us.
Yeah.
I want to make just a comment about navigation. I think navigation is necessary, but for the residents that we have, starting with the navigation means if you don't know the classical techniques, so what will we do in the places if we don't have the navigation system? This is the problem, I think. We're also using navigation, and it's very comfortable, it's more safe, but if you don't have the chance to use the navigation, so if you have started with navigation, so what will we do, Corinna?
Yeah, that's the problem that's the problem that I was kind of mentioning with our current residents, where we have hit this inflection point where the residents that I'm training now are doing more navigation cases than freehand cases. So, the issue I have is as an academic neurosurgeon, it's two things, right? I have, I'm always thinking about my patient first and foremost, and then I'm also thinking about training. And how can I, do something, I can't, switch half of my cases to freehand, even though I think that navigation is safer when we have that technology. So what I'll do is in the case, I will force the resident to show me the anatomy first, so those anatomic landmarks I went through at the beginning of the case, especially in the thoracic spine, because I think that residents find that to be one of the most challenging, some of the more challenging screws. And so I'll force them to say, okay, where would you go freehand? Where would your entry point be? Show me where you would be, and then only look up at the screen afterwards. So I think, we have, and then, you want to be modifying things 1 or 2 millimeters, right? You don't want them to be completely off. So I think that's one technique that I try to do. It's obviously not the same because it's a crutch. But I think this is, one of the things that we have to discuss, obviously. I think that some of the, I didn't talk about these technologies and I personally don't use them, but, we do have some of the kind of, the AR, VR goggles, some of the cheaper technologies that have price points of just a few $1,000s. And those basically overlay the screw trajectories onto your view on the field. And so those maybe those will be a solution to provide, navigation technologies at a cheaper cost, in certain locations. But I agree with you. I think that it's definitely a big problem and something that I think about a lot.
Yeah, I agree. I think cadaver workshops make up for some of the problems and sawbones, but obviously it's not the same. But at the same time, you majority of the time you learn your basic from there and then pick up as you go along. But as you said, probably the best way is for them to have the feel as well of where exactly you're going to be going, and then see how accurate you are, and keep doing that. And that's the only way of making sure they learn. And they need to read up as well, much more than just seeing things on the robot or with the help of image guidance, etc. So there's lots to be done.
There is one question from audience. Dr. Khan is asking if thoracic disc is removed from one side, is it mandatory to fix the spine?
Corinna, this is for you. If the thoracic disc is
This one is for me.
Yep.
I don't think it necessarily has to. It depends on, the situation. If they're asking about the case that I showed at, the third case I showed, that patient had already had that I had not done, had a fusion on one side with screws and a rod on one side. So, obviously in that case, Also, so I did. I think that in that particular case, so if I'm doing if I'm doing a transpedicular or costotransversectomy approach, then yes, I do do a fusion. And I personally just do bilateral fusions with pedicle screws on both sides. I think if you're doing a lateral approach and you're just doing a discectomy, then you do not need to do a fusion of the spine. So I think that's another potential advantage. And that can be good both for a soft or potentially also for, a calcified disc in a different situation. So I hope that that kind of addresses that question.
Okay, very good. Any more questions?
Me not.
Okay.
Thank you.
Okay,
It
so I
was-
think it's Mehmet, you want to thank everybody and then we can wrap off.
Yeah. Thank you really, Dr. Zanchen, Dr. Corinna, Dr. Roger. Actually, I also thank all the participants for coming and taking time with us. Thank you, Salman.
Thank you very much. So hope to see you soon. All right, guys. Really our pleasure as well. Take care. Bye-bye.
Goodbye.
Just have a picture before we go. Smile. All right. Bye-bye.
Bye bye.